All right, good morning, everyone. It's very nice to be here. I want to thank the NSDA for inviting me, and I want to especially thank Dr. Courey for setting up this panel. We're going to talk a little bit about Botox and get into the medical topics for the morning. So, as you may know, Botox is actually known for botulism. If the seal is broken, don't consume. It's a pretty nice thing I saw here. So this is actually the bacteria that makes makes Botox. Of course, it comes like this now in a very nice vial. It's mostly known for cosmetic applications. In 2013, they sold $6 billion worth of Botox. And it's also known, it's actually a known bioweapon. I didn't actually realize this until I looked into this. Apparently a gram of Botox can kill a million people. So you actually guys are getting bioweapon, which is also obviously a magic drug for the disorders that we have. So, there's a various background of people here, so I wanted to put a few slides on the Botox and its mechanism. It's an exotoxin from Clostridium botulinum bacteria. It blocks the neuromuscular transmission at the neuromuscular junction. There are lots and lots of types of Botox, A, B, C, D, E, F, G. A and B is commercially available in the US, and neither is actually FDA approved for spasmodic dysphonia. It's approved for a lot of other things like cervical dystonia, strabismus, etc. Here's the neuromuscular junction here, and Botox prevents release of the neurotransmitter acetylcholine, which is necessary for contraction of the muscle. And if you're more into how it works, these are these wormy little things that need to interact at the neuromuscular junction, and Botox prevents these guys from interacting. And this is actually the structure of Botox if you're like a biochemist like me. So our association, American Academy of Otolaryngology, actually came up with a statement saying that the AOHNS considers Botox a safe and effective modality for the treatment of spasmodic dysphonia and may be offered as a primary therapy for this disorder. So we're going to go right into injection methods, and I'm going to start briefly, and I'll be followed by Dr. Courey and Dr. Damrose. Oh, I forgot to introduce the panel. I think you guys all know our panelist. Dr. Damrose is from Stanford. He has actually got the job that I wanted. Ed graduated just before me from UCLA. And then Dr. Courey is at UCSF, obviously. He is where I actually wanted to go to medical school. And then Dr. DiRenzo came all the way from the Midwest to be in California because she heard that everything, all the gold is in California. So probably you guys know all about this, but just as a preview, there's lots of methods of injecting Botox. All are effective. None have been really compared to one another. And I think we'll cover all these approaches by the time the three of us are gone through this. The target muscle for adductor spasmodic dysphonia are these two muscles. There is the thyroarytenoid muscle, and that's the main muscle that allows us to control our voice and speech. And then there is another muscle called the lateral cricoarytenoid, which actually closes the vocal fold in the back. There's also another muscle that adducts the vocal cords called the interarytenoid muscle, but it's kind of hard to target easily, so we don't really tend to inject that muscle, although there is research showing the interarytenoid muscle is also involved in adductor spasmodic dysphonia. As we discussed earlier, it's actually a mixed disorder affecting all the muscles. For abductor spasmodic dysphonia, the only abductor of the larynx is the posterior cricoarytenoid muscle, and that's what we're trying to target with Botox. So I use the cartilage and transmembrane methods. Dr. Damrose will describe this in detail later, so I'm going to show you my video. So this is pretty much how I inject for adductor spasmodic dysphonia. So what I'm doing is I put my finger in the space between the cricoid and the thyroid cartilage. That's called the cricothyroid membrane. Then I feel the needle pop through the cartilage and then inject. So the PCA is a little bit harder to get to. You can go behind the larynx, or you can go, by rotating the larynx, you can see in the left lower hand corner, or you can, on the right upper hand corner, you can go right through the cricothyroid membrane. If you point straight backwards and slightly off to the angle, you will actually find the posterior cricoarytenoid muscle. So this is an injection, and right below you will see that the needle will come through the cricothyroid membrane. If you can see just below the vocal cords, I'll point towards the muscle and then inject it by going through the cricoid cartilage.
Thank you. And one question, Dinish, do you use topical anesthesia?
I do not.
You do not. Do you use intralaryngeal anesthesia when you're...
No, because I don't enter the...
For the PCA, though?
Oh, for the PCA, yes.
Okay.
I will spray some lidocaine through the cricothyroid membrane before we inject it.
I've never read that warning. All right, so I like to do, I do it with the patient seated. I use EMG guidance. I use topical anesthesia to the skin only. And for the adductor SD, I inject through the cricothyroid membrane, staying submucosal. And I think the advantage of this is you don't need any intralaryngeal anesthesia. Dripping laryngeal anesthesia is often what patients don't like. And for the abductor, I do rotate the larynx, and I try to stay submucosal as well. So what I don't do is I don't use a transnasal or a transoral endoscope to visualize. And I know that there are many surgeons out there who do it that way, but I find that the patients who end up coming with me, and I can't tell fibs in this room, don't like it or appreciate not using it. I don't topically anesthetize the larynx, and I don't pierce through the thyroid cartilage. So for the adductor SD, the historical dosing is somewhere in the range for unilateral dosing of 15 to 30 units. And, originally, I think before Botox became popular for this, Dr. Scott, who brought Botox into medicine from the military, it was originally designed as a chemical warfare drug, as Dinish alluded to. And in the 1980s, he was at UCSF as an ophthalmologist and brought it into the medical arena there for the treatment of strabismus. And so, I guess late 70s, his book was published in the 80s. And so there's a relatively long tradition of using it, but the original injectors, not at UCSF, more in New York and at NIH, were injecting between 15 and 30 units into one vocal fold. And really the goal was to mimic, on a temporary basis, the results of a unilateral paralysis procedure. So I think that was the intent. And then the same physicians, Dr. Rue et al., talked about injecting 2.5 units on a side to 15 simultaneously, as opposed to 15 or 30 units into one side. And found that in a small study of like 12 patients, the patients didn't really find a difference for either technique, but it wasn't a blinded crossover study, and I think patients are happy. So there was some, it could have been more powered. It could have been more powered. Back when I first started at Vanderbilt, Mike Karuchik was one of our residents, and Jim Netterville was the person who taught me how to do Botox injections into the larynx. It started with the concept of maybe 2.5 units per side is too much. And so let's try this low-dose alternating side. And so this is my injection style, and this is my preferred injection style today. I remember a cardiologist that I used to treat when I lived in Nashville, and he would come in and say, well, my transcriptionist told me it's time to get another injection, and that's what he would use as his key. And what we would do is 1 unit into alternating vocal folds every 8 to 10 weeks for him. And that way he avoided some of the, which we'll talk about later, is the pitfalls of Botox, which is the periods of overtreatment and undertreatment. So what we found in that study from 1996 is that it reduced the overtreatment phase by about 50% in length and severity. And then it reduced the well-treated phase by about 30%. So patients definitely needed more frequent injections, but there wasn't the ups and downs of treatment. So currently, though, I start at 1.25 units per side, and I do it bilaterally unless the patient lives very close, because this is a diagnosis of exclusion, and I want to be certain that I hit it. And even though we've looked at our hit rate, our success rate is about 96% of getting the Botox into the position that we want. And still, if you have both sides to treat, if you miss one, you're more likely to at least get some response. So it helps not only give the patient some confidence that there's relief out there for them, but it gives us confidence that there is potentially some diagnosis. And if the patient is too breathy or has too severe or too long of a breathy phase after that initial bilateral injection with 1.25 units per side, we'll start lowering the dose. And I talk to the patients, do you want me to do an alternating unilateral dose? Because that's really quick. Or do you want me to do low dose bilateral? And sometimes I feel like patients with tremor or a significant tremor component get better responses to a bilateral injection, so I'll try to encourage them that way. Other times I try to encourage them into the alternating unilateral dosing schedule. The difficulty with that is about a third of the patients will still never get to a totally smooth voice. They'll have some degree of spasms persistent with the alternating, where's Dr. Tom? I've got to breathe. With the alternating unilateral injections, that they will still find that they're still slightly spasmodic. And so about a third of them will want to go back to the low-dose bilateral injection schedule. And for the abductor historical dosing, we used to start at 7.5 units. I inject alternating sides. And people have also reported injecting 3.75 units in one side and at the same setting, injecting 1.25 units into the second side. But what I found over the years is that really into the PCA muscle, 3.75 units can produce pretty dense denervation if you're getting it into the right spot. So that's now my starting dose, and it ranged between 1.25 and 3.75. So we'll just go for time. Dinesh has already showed the adductor technique. So for time, we'll go over the abductor technique. So for time, we'll go over the adductor technique. Inject into the TA-LCA complex. I don't know that I can separate these muscles, which one I'm in. And I use topical anesthesia over the skin. And this is the injection. And I do use EMG guidance. So the patient has references, and then our active electrode is the needle. This is a Teflon-coated needle. So we're running the EMG signal. And then there's a ground electrode on the patient's forehead. Feeling the cricothyroid membrane, just like Dinesh showed us. I'm going through the cricothyroid membrane at an angle up towards her ipsilateral ear. Same thing, having her phonate E. And it is usually that quick. Okay. So for abductor SD, I prefer to rotate the larynx and inject the PCA primarily. I do use alternating sides. The difficulties with abductor SD is that it does not eliminate spasms completely, and you have to be cautious that too much abductor weakness can lead to airway compromise. Finally, only about 50% of patients with abductor SD find that the treatment options, at least the ones I offer, are of significant benefit to them. Thank you.
Good morning, and thank you for allowing me to speak today. I'm Edward Damrose, and I'm from Stanford University. I'd like to thank the NSDA and Dr. Courey, Dr. Chhreti for the opportunity to be here today and to speak. I also want to thank my wonderful patients who are the reason that I am here and do what we do. I see many of you out in the audience today, and I'm going to be glad to see you back in the clinic. Hopefully not too soon for an injection, but just come down. When we have these discussions about how I do it, I do want to say just one thing out there. If you're hearing multiple techniques, it probably means that there's more than one way to skin a cat. Most of us that do surgery tend to gravitate towards the technique that allows us to be the most successful for you. So if you're kind of thinking about and hearing about some of these things today, just keep in mind that there's many ways to do this. Those of us that do Botox injections, we're picking the technique that allows us to do the best job that we can for you. So if you come on down to Stanford, I'll tell you the way I tend to do most of my injections is through a technique called the point touch technique. This is a technique that I learned from my mentor and teacher, Dr. Gerald Burke. And over 20 years, I never have found a reason to change my method of doing this. We also do EMG guidance as well, as Dr. Courey has mentioned, since my partner Kwan Sung joined us several years ago, and this tends to be his preferred technique. Occasionally we do use a fiber optic scope placed into the nose, although that's rare. Generally we do that when I find the ability to feel the landmarks externally is difficult. And then for those patients that are interested, we also will perform surgery as well. So I'm going to just tell you a little bit about the point touch technique. Again, this was described by Dr. Burke many years ago, but it relies on the fact that the external landmarks of the laryngeal cartilage and the framework are relatively easy to palpate. And if you can, thank you very much. And if you can actually palpate those landmarks, well, I'll do it with the arrow a little bit here. then it's easy to know where the vocal cord is, relatively speaking, and then where to put the injection in. So I do inject the vocal cord in two different ways primarily. One is either through the cartilage in patients where the cartilage is soft, and then one just really wants to kind of pierce that cartilage and get into the muscle space and then apply the injectable. But for most of our patients that are older where the cartilage is calcified, it's not always easy to get through that cartilage, and therefore we'll go under the cricothyroid membrane, sometimes give the needle a little bend, and then go ahead and just inject right in there. But again, this relies on being able to palpate and feel the external landmarks of the voice box, which fortunately we can in most patients. Probably for those, again, that don't have landmarks that are easily palpated, if they're somewhat obese or if they've had surgery in the front of the neck, sometimes passing the fiber optic scope down to visualize the vocal cords is helpful. When you actually inject the Botox, you can see the vocal fold bulge, which can help confirm to you that you're in the right place. I was thinking a little bit about, why we adopted the technique that we did, and a lot of this has to do with, the place where you practice. I can remember when I first came to Stanford and I wanted to set up a voice center and I wanted to do Botox, I was told, no, you can't, because Botox is a chemical weapon and the patient may get out there and, the World War III will happen, and so it was a real struggle to get Botox. And then they told us that, well, you can do Botox, but you're going to have to open up one bottle for every person. You're going to have to throw everything away because it's a single-use vial only. We said, well, that's going to be rather expensive, right? Because we only use like a half a unit out of a 100-unit bottle. And they said, well, that's okay. So we started to do that, and the patient said to us, you know what? I'm paying for this bottle. Why can't I just take it with me? And it's like, well, that's a good idea. And I went back to Stanford and I said, our patients are paying for this and they want to take the botulinum toxin with them. And then we kind of sat down and thought, is that really a good idea that patients are walking out the door with botulinum toxin?
Doctors Chhreti and Dinish from Southern California are in horror that you're having to do this, but we have to remember we're in Northern California.
That's right.
Right. So, and Stanford is a super highly regulated place to practice. So when we went back and said, maybe it wouldn't look so good if people are, leaving with a biological weapon. Okay, so you can do Botox and you can do one bottle for patients. So as a result of these machinations we go through, we tend to offer a clinic about roughly every 2 weeks. This allows us to bring a whole lot of patients in at once, open up one bottle, which allows us to basically contain the cost. And this is what I think how most people out there operate when they use botulinum toxin. We don't have specialty appointments, for example, where you need to come in. And again, because this is the point touch technique, and we're not really using a neurologist or another operator to help us, it was another way to get around a problem. If we try to combine visits with a neurologist, it's a terrible experience for the patient. Anybody that's been to Stanford, you have to pay for parking, and then you've got to take a tram around and go to try to find all these people. So it was just easier to make it a one-person only, do this. My fellow who actually watched me do this, and I think Dinesh's video will show you this, it's actually pretty quick. It only takes us about 30 seconds for most patients, and it varies roughly around 5 to 90 seconds, depending on what we're doing. And then if we miss, and a lot of our patients know if we miss, they'll swallow the medicine or it just didn't take, it's relatively easy for us to reschedule the appointment. So this was just a little bit of data that one of our fellows put together a few years ago looking at our success with the point touch technique. And we looked at about 37 patients. Interestingly, women to male were about 2-to-1 ratio. The mean age was about 56. Most of our patients received on average about 0.88 units, and it varies from 0.15 to 5. Most of the injections last around 26 weeks or so, with some variability from 7 to 73 weeks. So patients come in and see us roughly every 26, 27 weeks for their injection. And one of the things we were interested in looking at this was if you eliminate the EMG component, is this still an effective technique? And one of the things we looked at was the voice-related quality of life. And you can see the domains here. The white figures over here, or the white squares rather, are prior to the injection, and then this is what happens to the emotional and psychological, and then the total domains over time. So if you actually look at this, the technique's pretty effective. More importantly, too, when you compare it to other techniques that tend to use EMG, pretty much what you're finding out is that when you use botulinum toxin to treat SD, you improve the patient's quality of life. You can use EMG, you can use the point touch technique, you can use a dirty rag on a stick as far as I'm concerned. But just get it in there and you'll help the patient. So that's how I do it. Thank you.
just had a couple of slides showing there's obviously you can also get it done orally, and that's how it's done. This is a really old slide somebody gave me. And then EMG guidance, I think we've covered. Technique comparisons have been done. There's really no difference, as Ed just said. And so then we'll talk about monitoring voice post-Botox injection with Dr. DiRenzo.
Thank you. So as Dinesh mentioned at the beginning, I'm fairly new to the Bay Area, and I work with Drs. Damrose and Sung at Stanford Voice and Swallow Center. And a very critical part of the Botox injection, in addition to the injection itself, is actually monitoring the results of the injection, because that's going to inform what we're doing in the future to try to help improve the voice. So how do we monitor Botox effectiveness? Well, if you look in the literature, and there's quite a bit of it, you'll see a huge number of ways that both clinicians and researchers are going to monitor the voice post-Botox injection to try to figure out how successful it was in relieving voice symptoms. The first kind of, subtype of ways to monitor voice is via objective voice measures. So this is things that we're actually looking at the pitch of your voice, the loudness of your voice, breaks in your voice. Those are acoustic type measures. Aerodynamics, so airflow, looking at the larynx, looking for those spasms, as well as EMG. So these are these ideas of objective voice measures post-Botox injection to, again, monitor the voice. However, in clinical reality is that most people are often traveling, often a significant distance to these voice centers to get their Botox injection. And people are not going to be coming back once a week, once every 2 weeks, even once a month post-Botox injection to have these objective voice measures completed. In fact, I like to think that patients like to say, thanks for the Botox, see you in 4 to 6 months. So how do we really are trying to mostly clinically monitoring voice post-Botox, and that's with perceptual voice measures. So that is having us as a clinicians listen to the patient and perceive how severe or how not severe their voice quality is. More and even probably important than clinician perception is patient perception of their voice quality. We can also do that, objectify that a little bit more with standardized quality of life measures. So let's take a look at the voice symptom timeline following Botox injections. And many of this has been alluded to with our other presenters. So here you can see, we have Botox on both ends, and I put about a 6-month time frame, but of course there's a lot of variability between patients. So I'm just going to start with is we can understand a little bit about the voice symptom timeline by actually understanding a little bit about how Botox works itself, as we discussed earlier. So it's essentially a form of temporary muscle denervation, and that happens with the Botox injection. At about 2 to 3 months, there's some reinnervation of that muscle begins, but not so much that we're actually no longer getting positive voice effects. And then the research says by about 4 to 5 months, reinnervation is complete, and that's when we're going to start seeing the symptom return. So with that being said, let's look at a little bit about what the voice matches up with in that timeline. So as pretty much all of our speakers mentioned up here, is that immediately following the injection, there's going to be some breathiness in the voice. And this happens in probably greater than 50% of the patients. We also worry about some dysphagia or swallowing problems. That's probably less, I would say, prevalent than we see the dysphagia. And on average, we're going to see this maybe anywhere from 2 to 3 weeks, but again, it can potentially be longer. Following that, we're going to see, hopefully then, a period of voice symptom relief. Again, variability, but we may see this up to 3 months. Or you can even see this longer, as Dr. Damrose had said, is I think, what did you say, 26 weeks was their mean time? So this is even longer. So it can go, to 5-6 months of symptom relief. But there's also going to start being, potentially after this 3-month point, some return of the spasmodic symptoms, the strain, the voice breaks. One study during this kind of golden period of voice symptom relief estimated that about 78% of patients were near normal. About 12% of patients demonstrated with mild kind of voice symptoms during this time, 1% of patients had moderate symptoms, and then 9% of the patients had no response to the Botox. Finally, eventually, this is temporary, there is going to be complete symptom return, and that's when it's time to, or hopefully maybe a little bit before that, to get a follow-up Botox injection. So with that being said, what are some factors for consideration in terms of monitoring the voice that we can use as clinicians to guide future therapy? Well, that duration of breathiness. So maybe if it's greater than 3 to 4 weeks, it's time to talk to your ENT to talk about, well, maybe changing the injection a little bit, reducing the dose, considerations of unilateral versus bilateral, and we're going to go into this more as the panel goes on and we discuss. Another factor to consider is your duration of symptom relief. Usually what we're going for is greater than or equal to 3 months of symptom relief. If you're seeing less than 3 months of relief, again, considerations to consider is this unilateral versus bilateral injection and potentially increase of Botox dose. So no symptom relief at all, and we'll discuss this as we move forward, and that may be time to potentially consider alternative diagnoses in addition to what I stated above in terms of this unilateral versus bilateral injection, or changing the Botox dose. So finally, a critical factor that we have to consider that we should never forget about is patient satisfaction. This is your voice, and if we perceive the results as good and you don't, then it doesn't really matter what we think. It matters what you think. So it's really important that you let us know about your perception of the treatment success, because I think that I speak for everyone here who's speaking that we'll do whatever we can to try to make you happy, because this is about you. So a couple other things to consider, and then we'll move forward, is that it often does take multiple injections to really achieve consistent voice results. On average in the literature, this is maybe 3 to 5 injections before we kind of really zone in on what we want. And it can be less. It can get it right on the first or second try, but it sometimes does take multiple injections. Finally, there is going to be significant variability in response to injections between patients. And that's important, that as you speak to the people here in this wonderful symposium, is that some people may say, well, I do this. Other people say, I do this. And, that's okay. We have to, again, find out what works for you specifically. Finally, it's important to remember that although symptoms may be almost completely resolved, that a completely normal, quote, voice is rarely achieved. It may be significantly better, but again, normal is hard. Okay, thank you.
So yeah, that was great. I really liked the part where you said about you tell us, how effective the last dose was. I know there are a lot of voice centers that will have patients fill surveys and how they do, and I tried to do that, but I found that to be kind of onerous. So now I just ask the patients, how was the last dose? How long was the breathy period? That's number one. How long did the good voice last? That's sort of what I use to decide what the next dose should be. And after the 3 or 4 injections, and we know what the right dose is, you guys, patients, are really good at knowing whether that last dose is good or not. You want to get a little bit more, a little bit less. So the first thing I know that Beth already covered this, and I wanted to ask the panel, what is a typical course of symptoms after Botox injection in your practice? Just in a very short answer.
Losing the voice a little bit for a while, a breathy or weak voice, and with some trouble swallowing is generally typical, and then that will give way to what should be a fairly normal voice. When we ask patients to come back, we want to ask them how long was that normal voice and how long was that unpleasant period, and try to adjust the dose accordingly.
So we're going for hopefully less than 2 weeks of a breathy phase, followed by 10 weeks or so of a well-treated phase, so 2.5 months.
Yeah, that sounds about right. I mean, I think more than 2 weeks is probably too long. I tend to shoot for 1 to 2 weeks, but I know that if the breathy period lasts a little longer, probably the effect also lasts a little longer, wouldn't you say?
Well, so we've shown that with the alternating low dose, that when you do reduce the breathy phase by 50%, you reduce the well-treated phase by 30%. But still, if patients live close and aren't traveling a long distance and the injection is a 5-minute visit and you can keep your clinic on schedule for them, I think many patients would prefer to have more frequent injections with less over-treatment. And that's what I try to encourage them for.
Great, yeah. So this was actually, Beth talked about this. This was actually a study by Randy Paniello showing this, what we now call the Botox cycle. You know, how the quality of life numbers are low at the beginning of injection, then it's high towards the middle, and then again you go down again, then the cycle is about 3 months. What about ABSD? How happy have you been treating ABSD with Botox?
I find that the folks with ABSD to be really challenging to treat. It's the injections are a little bit more difficult to place, and I've found that a lot of the times the effects are just not quite what the patients are looking for. It's a tough condition to treat.
So this is one of helping set expectations on the part of the patient and the treating clinician too. I think that Andy Blitzer has actually published on this as well, saying that really only about 50% of patients achieve a meaningful result that they want to continue injections. And so we're not going in this population for normal spasm-free voice, we're going for less effort and more intelligible voice, and we try to counsel them that way. So.
And apparently there is a chart in tracking your Botox results in the NSDA website, so that would probably be also useful to look at and bring to your physician. And I would say, yeah, I mean, this is, just wanted you guys to hear this.
Okay, my voice cracks when I talk.
So
It's always like that.
That's, oopsie, hang on. So pre-op and post-Botox. All right, well, if I can't play, you can still hear some ABSD.
I've been doing fine. I think my voice is a lot better.
Better, but not
I work as a nurse.
completely normal.
But for abductive SD, that's almost a home run that you show.
Yeah.
That's what you're going for, and that's the challenge of setting patient expectations, and that's our limitation.
Exactly. So that's part of what I wanted to point out, is that even if you get some improvement, that's probably getting someplace. So the second question that we hear all the time is, you know, we talked about this a little bit. Why do my injection results vary so much? And why doesn't Botox work for me anymore? And Mark, you talked about the doses you use. Can you talk a little bit about, does it matter if the gender, the severity of spasmodic dysphonia, does that make a difference in terms of the dose you start at?
So we've already looked at that, and it doesn't. The severity that we perceive does not correlate with the absolute Botox dose required to treat symptoms. But having said that, when a patient comes in with what I perceive as mild spasms and lives less of a distance from me, I will start out with a unilateral treatment option for that particular patient, as long as they're willing to come back next week.
Okay. But you, Ed, what dose do you start at?
So, you know, like for patients, when I first see them, I tend to do a unilateral injection. I try to err on the side of a lower dose. I'm concerned when patients are getting Botox for the first time that the side effects may be overwhelming to them. Having their voice change and do things out of their control is very disconcerting. And when you add things like dysphagia and now they're choking, it can be real problematic. And I tend to favor a lower dose, so for example, a quarter of a half unit to one side.
So yeah, I think, you know, when the studies first came, they were using a much higher dose, but as time has passed, we are all using a lot lower doses. So I would say my starting dose usually is about a unit for females, maybe 1.5 for males, and I do go by SD severity to kind of decide. So there's a question from the audience, and it says, I thought frequent injections will destroy antibodies. And maybe, I don't know the answer to this question, maybe Dr. Burke can chime in too. There was all this discussions about Botox resistance, right? And now I don't really hear that anymore. So was that just a fad that went away, or does that still exist? We just don't know, or what do you guys think?
So, you know, there's been a few reported cases of patients with SD developing antibodies towards Botox, but it's a very few reported cases. And the development of resistance seems to be getting large doses more frequently than every 3 months. So in the neurology practice where they're injecting 100 to 400 units or more, they can only be injected every 3 months, and they won't inject more frequently to reduce the risk of antibody formation. In our population where they're getting an average 2 units per injection, I don't think it's been reported, and I have not had a patient I think what happens is patients age, and you alluded this into your last slide, their voice changes. They may develop concomitant tremor now.
Yeah.
So they have SD plus tremor, and so they're not getting rid of their tremor, or they have SD plus bilateral vocal fold atrophy. So they're not getting rid of their vocal fold atrophy. I mean, the way we can prove resistance is if you can inject half their forehead and find out whether or not they... Yeah. Well, then you bring them back the next week and you inject the other half.
I hadn't thought of that. That's a great idea because I always thought, we talked about an autoimmune mechanism causing you to be resistant to Botox, but it's really not something we discuss anymore. So maybe I'll try that next time. That's a great idea. All right, Dr. Burke.
Yeah, I agree with Mark. It's very, very rare. In fact, I remember one lady many, many years ago, I've been giving Botox since 1984 or 5. It's a long time. And she came in and she said, "Can you give me 100 units?" And I nearly fell off my chair when she said that to me. She said, "Yeah, no, I have autoantibodies to it." And indeed she was. There actually is a place that you can send off blood to find out if they have. And fortunately, now that they've developed a couple other forms of Botox, there's a Botox B, you can actually treat some of these patients, not quite as effectively, but it's a very rare condition to have somebody with antibodies to it, and I wouldn't be concerned about it unless you're getting really large doses over a short period of time.
I know that neurologists are more concerned about this, and when they send me patients who they are treating concomitantly for other dystonias, they will always try to schedule it around the same day because of the concern. So I think that's reasonable to do it that way. Okay, so the difference between unilateral and bilateral, due to the time constraint, I'll just discuss this very shortly. Obviously, with unilateral, there's a shorter breathy period, but early return of spasmodic symptoms, slightly higher failure rate with the unilateral injection. With the bilateral, longer breathy period, longer control of voice symptoms, and lower failure rate. I guess unilateral is a useful approach in those who cannot tolerate a prolonged post-injection breathy period. And I would say that the proportion of patients I inject unilateral is quite low compared to bilateral. Any comments about that?
So I probably inject 50% of the patients unilaterally.
50%.
Yeah, I'd probably say that's about right too. It seems that patients do seem to do pretty well with unilateral injections, and it seems to minimize the side effects. We do have a number of patients that live locally that come back for fairly frequent injections, so I think it's been a good strategy for us.
Okay, and the dose you use for the unilateral?
Again, probably about 1/4 to 1/2 on average.
Okay.
So it is interesting too. I perceive differences in what patients will tolerate between here and when I used to live in the Mid-South in Nashville, Tennessee. People here, particularly women, and I've talked about some business women, are really intolerant of any prolonged or any real perceived breathiness or vocal weakness. It's different, and I don't know if you all want to discuss that at some point, but there's a different willingness to tolerate things regionally.
All right, we won't make fun of the South. So what about this? Something patients say, Botox.
Not better or worse.
Botox never worked for me, or Botox stopped working. What do you think is going on?
That's a great question. I sometimes makes me question the diagnosis. If I've never injected the patient before, I'll often say, well, let me give it a shot so I know maybe it's an operator-dependent issue. If there's really a question that the Botox isn't getting in, I've taken patients to the operating room to inject directly in to try to confirm that. I think that in situations where it seems to never work, maybe the diagnosis may be in question, or it's a mixed issue where we're just not hearing any advantage. Stop working. I have to say that I've had, anecdotally speaking, 2 patients over the years, both had sustained strokes after having, not from the Botox, but after having gotten an injection for a long time. And the Botox just seemed to stop working. We just couldn't control their symptoms, and I think it has something to do with, Mark alluded to, a change in their neurological status, obviously.
Yeah.
No, I would agree with what Ed said. If the Botox never worked, you consider the diagnosis and you consider who and where the previous injections were done. And even myself, if I diagnose with my speech-language pathology colleagues, somebody's having SD and I don't get it to work, then I really have to consider our diagnosis. Was it
Okay.
right?
Yeah, just to add to that too, I think that at that point in time too, it is always worth a trial of if we're other concurrent common concurrent is vocal tremor, but also differential diagnosis is muscle tension dysphonia, which is treated by a speech language pathologist. So, if the Botox never works, send the patient for some active therapy to a speech language pathologist to assess to see if that's effective. And, behavioral treatment, it's not a huge amount of time, and I think certainly worth that.
Okay, yeah, I agree. I think we have to look at the differential diagnosis. That's kind of what I wanted to allude to. And, there are some techniques to know the difference between SD versus tremor. And of course, SD and tremor can come together, and it's harder to treat the tremor component compared to the SD component. Just a video showing irregular rhythmic tremor of the entire larynx and pharynx and tremor versus ADSD. And obviously, the other differential diagnosis is MTD, where if it's an extreme MTD, it can be difficult to differentiate that between SD and that. And of course, the classic presentation of SD responds best to Botox, and the ones where even the doctor has difficulty figuring out what it is are less likely to respond to Botox. So that's the way I think about when it doesn't work. And then, obviously, if you think it's MTD, just do a trial of voice therapy. Supposedly, voice therapy will work for it, so that might be a diagnostic thing to do. And so lastly, I want to talk about the ugly parts of Botox injections. Mark, what are the limitations of Botox injections?
Well, it's treating the end organ, it's not treating the source. So it's a way to help patients get by with their disease process. It produces symptomatic relief only. It requires that we repeat it regularly.
Right. Ed?
I think one of the limitations is that it obligates the patient to maintain a relationship with their doctor or their speech pathologist the rest of their life. They're never really free to move about the cabin, so to speak. And it's one argument to consider for surgery. Try to cure their symptoms so they're free of this.
Okay, that's a good segue to the next segment, so you can decide if you want a bioweapon or just plain old surgery.